But at what point does it become serious? I'm going to keep it as a simple message. Just to give you an idea, I've never not taken an x-ray. That was a double negative, but you'll understand. Since 1995 when I graduated. So I've never seen a patient in practice for the past 28 years that I haven't taken an x-ray on. I actually, in school, I was a TA for the technique classes, and I was a TA for radiology. And it's actually the way, because while I was TAing for radiology, it's the way that I actually started bumping into what Deed was doing and Don was doing, actually more Don at that time, but Deed was on his way up, just with pre and post x-ray. And I heard about them getting results, and that's really kind of led me into, wanting to see more of the spine and how chiropractic can affect that spine. So the only time I haven't taken an x-ray in practice is that if the patient was pregnant or is pregnant, or if the patient couldn't stand up on their own. As soon as they can stand up on their own, 4 or 5 years old, and taking x-rays. And I guess the simple message that I want to actually discuss today is, and it's something that you guys have to ask yourselves, is at what point does scoliosis become serious in your practice? Like, at what stage, at what point in your practice throughout a lifetime, does scoliosis get serious? And let's start off with Annette. Annette came in just a little bit ago. Actually, she came in late August, and cervical x-ray. So one of the things you'll see, and Pascal probably discuss, is like when there's scoliosis or any like major translation to the spine, the neck is always going to be actually involved, and you'll start to see some pretty funky upper cervical stuff. A lot of reversals, a lot of stuff that you would not necessarily always see in just the people without these massive shifts and curves. So neck comes in with, her neck, 53 mils of anterior translation. Obviously, we know, the more the spine goes forward, we increase what I guess for every inch forward, increase the pressure on the lower C-spine by 10 pounds. You can start to see here that 5-6 starts blowing out here. That's the only area with spinal damage at this point. A little bit of 6-7, but that's normal too with this type of shape. And you just see some cervical clips. You see some thyroid clips here. Wonder if there's a connection. And then we take another X-ray, and this is her upper thorax. And listen, you have to understand too. And let's go to one more X-ray. So she came in and she said that she was only been experiencing pain for about 4 weeks. And I'm going like, what? She's been only experiencing back pain for 4 weeks, but she walks with the walker, and she cannot walk with her walker for more than 10 minutes. She's been in her care 3 times a week since August. Now she came in and she just said that now she can walk all day with her walker. And to me, that's awesome, right? When I look at a scoliosis like this, what I see is chaos, right? What I see is chaos, and I believe as the chaos in the world increases, we're going to see more and more chaos within spines. And so what I want to do when I see chaos, I want to bring order to it, like regards to the amount of order, but I want to like shoot for order, shoot for alignment, and that's going to bring order within the body. This touches home too because Karen, so Holly's mom, Karen, 2 years ago, she's had a scoliosis, obviously, for, well, we believe since childhood. And we've just seen her throughout we've been married for 27 years. Since we've been married, I've been trying to get her to see a chiropractor. She'd be going to see chiropractors, and I would be going, I'd be giving the recommendation, and here's a 91, just show up, show them this in their small town, and just tell them that you can prepay the whole thing. And then the chiropractors would always come back with, well, I can't correct this. I can't really help this. And I'm going like, oh my goodness, I want to give a few of them a shake, right? It's just like, okay, so you can't correct it, but just keep her mobile. Keep it like a functional scoliosis. Keep her mobile, because we know that there's very, very specific load moments here that are going to break down, okay, over time. So we just saw her get slower and slower and slower. She started walking with a walker, and then she started actually not being able to get more than, she's not 9 degrees. She's kind of get higher than 45 up. And with posture, slowing the shuffle stepping. And then 2 years ago, she finally actually had a compression fracture. So, and which actually sent her, now she's crawling around the house. When she wants to go from the bed to the bathroom, she crawls. When she wants to go to actually try to grab a bite to eat in the kitchen, she crawls from her bedroom to her kitchen. She's got this compression fracture. She was able to go to the Mayo Clinic. Now, first of all, where do you think a compression fracture is going to actually happen in the spine? Well, it's going to happen at the biggest stress and load moment, which is going to be in this area here. You guys can't see me with my pen. In this area here, or it's going to be in this area here. Well, it happened in this area here. So now she's in devastating amount of pain. She can't move. So she actually gets sent to the Mayo Clinic, which is an amazing clinic in Rochester, Minnesota, cutting edge in a lot of things. Well, one of the things that they're able to do with compression fractures is they did spinal surgery, and they go in and they put a balloon in and they pump the balloon up to try to bring the compression fracture up. Why they're trying to do that is because they're trying to reduce the curve, right? They're trying to reduce the curve. So they do that. Well, was it deemed a success? Well, she was able to reduce some of her oxycontin and oxycodone. She's lost her mobility. She walks pretty much full time with a walker now. She's with the Holly right now. And so I took a little bit of pain away, but she's lost all of her function, right? To the point now where she's going to be going into a home. Last year, she actually was airlifted. We got a call from the airlift crew. She was being airlifted from the Mayo Clinic, from the hometown to the Mayo Clinic with a dissecting aortic aneurysm in the aortic arch. So here again, the aortic arch is up here, right? Okay, so dissecting aortic aneurysm at one of the apex of the curves. Do you guys think that it just so happens to be with severe scoliosis, there's an increased incidence of dissecting aneurysm in the aortic arch? Well, thankfully, it wasn't luck. We were praying a lot, but they did a great job with saving her life. But at what point does it become serious, right? At what point? Well, let's go to Lucia. Lucia's been a patient for like 10 plus years. Okay, so anterior carriage, decreased curve. What's blowing out? 5-6. That's spinal mechanics. Here's Lucia. Now, Lucia, this is her X-ray in 2021. She actually does aerobics every day. She does yoga. She actually bikes. She's very, very athletic. And so she's 62 years old. She's got, now we've had a lot of correction with this lower back, but she's still really, really crooked, right? And on top of that is that, the specialists are in spinal mechanics are the ones that have actually used X-ray as diagnosis, how to do their protocols, and as prognosis for the patient, because we're the ones that see the X-rays. I'm so sick and tired of hearing like the chiropractic marketing control the narratives of chiropractic. So sick of hearing the coaches says, well, do we really need X-rays? You know what? Yeah, I'm a chiropractor. I want to see the spine. Because you know what? With Lucia, well, you got her curve, but you know what? You see this big, massive osteophyte here? Why do you think there's a big, massive osteophyte? Because this is another load moment area that you wouldn't know about unless you saw the X-ray and see the X-rays over years. If you see a patient once and never see them again, you can't have a clue about how X-rays degenerate over time, how a person's life degenerates over time, if you don't see them throughout a lifetime. So we're the specialists. I would just wish that, because back in the olden days, to become a specialist, you had to be really good. There's a whole bunch of like pie holes that actually need to be shut right now. Moving right along. Mike, 64, he could not, he's a lawyer. He came in July 2022. He couldn't move, okay? He can't bend down. He walked in with slippers because he hasn't seen his feet in the past year because he can't move. So he's a lawyer walking around with slippers, 60 mils anterior carriage, blowing out 567. This is him, I forget the date on this. This is him about 6 months, 7 months later, okay? 60 reduced to 45, curves coming back. Look at that. That's awesome. Okay. Mike has actually had, from July 2022, I just saw him yesterday, 147 adjustments. But I got him walking again. And now he comes in with shoes now because he can actually tie his shoes up. This is him, July 2022. Well, there's a whole bunch of disc wedging there, right? Where do you think the bulge is going to end up? Posterior, lateral, on what side, right? This is him, February 2023. Now, is there improvement? Absolutely. Look at the disc spacing. The wedging is getting better. He's moving, and he's a 64-year-old with teenagers. He wants to be around. Well, the way he was going, I told him he was going into the home within the next 10 years. If you can't move now, you got about 10 years. You're going to be immobile completely, paying thousands of dollars a month for somebody else to actually take care of the basic needs that most of us take for granted every day. Susan, 60 years old. She just came in July 2023. Reversal. See, that's what I'm talking about, these funky necks, right? Reversal, massive blowout, right? 5, 6, 7. Massive osteophytes, or spondylophytes is the correct actually term, but we'll use spurring, right? This is Susan, upper back. Susan, lower back. These images too, there's some of them that are not too clear because I was using my iPhone to take all these pictures off of our monitors. She comes in and she's in massive pain. She can't even lay on her back, okay? She can't lay on her back without having massive pain. So her pain hasn't changed that much. Her function is getting better. I got her neck mobile again because initially she was not moving at all. But she's becoming functional, but she still has a lot of pain. And I simply said, you know what? I know you got a lot of pain that when you're laying on your back. But what I'm trying to do is not have you lay on your back for the rest of your life. So it's not that I don't hear you don't have pain. It's just going to take time, and it's going to take years. Right? It's going to take years. And she says, will I have to see you for the rest of my life? Well, it depends. How long you want to keep standing? Vincente, okay? Funky reversal, right? Reversal at 3-4, posterior apex, right? That's August 2022. He's in massive pain, has seen all sorts of spinal surgeons and spinal specialists, massive pain. He's from South America. Well, this is him, March 2023. 110, 115 adjustments over the past year. Okay, is it worth it? When does it become serious? This is lower back, right? Massive curvature, massive disc wedging, massive 21 mils on the pelvic, right? 17 mils on the hips. From August 2022 to September 2023, 110, 115 adjustments approximately. Look, is it better? Yeah. Is it perfect? No. But we're restoring order. Chaos towards order. Misalignment towards alignment. Bringing order within the body. 21 down to 12. Is it worth it? Well, it is to Vincente. He's a professional symphony music guy. He couldn't even play anymore. Okay. So the question you have to ask, when do I take this seriously? Do I really believe that I'm changing the world one spine at a time? Stephanie, 15, comes in January 2020. Well, 8 weeks after January 2020, you know what happened? Chaos, right? Crazy chaos with crazy leaders, right? Don't see her, doesn't start care. Just took an x-ray of her, came back in October 2025. She's an amazing hockey player. She's 15 years old, but she plays U18 and she plays I don't know if it's U20 or U21. She's an amazing goaltender, but has actually got hit with concussions repetitively. Well, you know what? I'm sitting down with mom and I just said, look, for 3 years, she's gone through a reversal. Just look at how thick this disc is right here. Well, this is the same disc, anterior wedging now. Where do you think the bulge is going to pop through? Stephanie, look from C1 down to T1. Pretty good alignment there. And like, oh, we're just a little crooked. What do we call that? You know, a mild, like what? Right convexity or left concavity? You know, mild to moderate, right? That's what the MDs, the radiologists would say, oh, that's normal. I see that all the time, right? Well, October 2023. Now look at this. Well, this zigzag here is still there, but look at now T1, T2, T3 going sideways. 2020, lower back. Okay, we got this curvature or list or whatever you guys want to call it. And we got something really funky happening at L4, L5. I've got my pelvic line in it that's hiding it, but this is wedging starting to happen. Well, a few weeks ago, I took another look. Look at this wedging. She's 15 years old. Okay. And the curve is going one way. Now the curve's going another way. In 3 years, she's going to look like 25, 35, 45. When does it become serious? Is this a scoliosis? By definition, no. Is it just as serious as one? Yes. Because I just have one level of seriousness for that patient in front of me. Billy, 12 years old, 2021. Mom brought her in because she's got this funky posture, right? She got this bad posture. You know what? I'm so sick and tired of hearing bad posture. Posture is a reflection of the spine. It's not bad posture, it's bad spine, right? It's bad spine. 1 year later, goes from 26 mils to 40 mils. Didn't start care, okay? It's more serious anterior, more serious reversal. Now get this, look at this. You know how I said it's connected, right? So bad posture brought to a GP. Oh, I see this all the time. She'll probably grow out of it, right? These little like shifts, right? No big deal. These lateral lists, right? Full-blown scoliosis. A year later, right? Look at this wedging here. Is that a load moment? Is that going to become a load moment for her when she's like 42, 52, 62, 72? Is that a load moment? Where do you think the compression fracture is going to happen at 62 or 72? Adele comes in, okay, with mid-back pain. His mom's a dentist that I've seen for years, okay? Got her curve back. She started to notice that he's got some postural issues and started to have back pain. So I take an x-ray, 9 years old. This is like a couple weeks ago. Whoa, Adele, not too shabby. Unfortunately, don't see too many of these anymore in grade schoolers, right? November 2023, mid-back. Load moment. Do you think this is causing his mid-back pain? When you do palpation, can you feel that shift? Most of you guys can feel that shift through palpation. Do you know how serious it is, though? You have no clue how serious it is unless you're taking x-rays. And if it's not serious, then you're not going to take x-rays. So when does it become serious for us, right? Mom saw that, boom, she's a dentist. She gets it. It's mechanics. She said, I can't wait to see the x-ray. Emery. So like Adele, remember? Adele had mid-back pain. Emery has no pain. I saw them. I did the reports on the same day, or the exams on the same day. Adele 9, Emery 9, same age. No symptoms other than she just kind of hunches forward. Mom doesn't like the posture. Mom's been a patient of mine for years. Whoa, 9 years old. Whoa, start of a reversal, 9 years old. No symptoms. Whoa, 9 years old. Load moment. No symptoms. Bad posture. No, not bad posture, bad spine. 80. 7 years old. Has seen specialists along the way because she kind of walks funny. She's kind of clumsy. She trips all the time. 7 years old. Okay. Anterior carriage of a 7-year-old. And we know that this curve, just with gravity and her being behind a desk and the computer for, 10 hours in her future as a student, with decreased recess time and decreased running around the playground time, decreased activity time, right? It's just going to get worse. Look at this. She's standing straight. And look at this. Now, could I palpate that? Yeah, absolutely. I could feel that. Could I motion palpate that and feel like the restrictions? No, I can feel the subluxation. Yeah, I can feel that, right? Can I see, check her pelvic heights, check her alignment, stuff like that, and see the distortions? Yeah. But what I want to see is the spine. Why? Because we're specialists. And the specialists that know the spine the most are the ones that understand the mechanics, not only from the motion palpation and the movement and the alignment and the posture, but also through X-ray. Because the more we've taken X-ray, the more we understand how this affects people throughout a lifetime. So coming back to Annette and my first question, when does this become serious for you? Because when it becomes serious for you, the patients are going to take it seriously. The patients are going to follow through, and the patients are going to actually allow you to step into their lives and change their spine one spine at a time.
Awesome. Great intro, Ed. Thank you. There's so many things I'm going to build on in my presentation that you hit on. Scoliosis is so important. And not only is it so important, so few chiropractors know what to do with it, and so few of them are good with it, right? Because the simple reason is we're simply not taught in school how to manage it properly. And if you know what to do with scoliosis patients, you can get phenomenal results. So first things first, let me make sure. Can everybody see my screen? Thumbs up if you see a screen. Yes, it worked, the share screen. Awesome. Okay, so scoliosis. So number one, we know what it is by definition. 10 degrees of curvature with rotation. And I want you guys to really understand the rotation, because the rotation is key. The rotation is the scary sign where things are going to get worse if we're not intervening. When does it become serious? If you're seeing rotation, it's beyond serious at that point. So any shift, any bending moment, any load moment, these are all super important for the spine. If you see rotation, especially in a growing spine, you have a serious problem and you need to intervene. Okay. What's really important to understand too is we've got 3 different curve types: lumbar, thoracolumbar, and thoracic. And in terms of managing them with home care protocols, they're all a little bit different. So I'm going to hit on single curves today. I'm not going to talk about double curves because that's beyond the scope of what we can talk about. And when we start talking about traction and exercises for double curves, it's not something that's done on a Scoli roll. Like, I don't send my patients with 2 big curves home. I don't send them home on a Scoli roll, because you're helping one curve, but you're allowing the other one to get worse. So when we're talking about complex cases, that would require oftentimes bracing or in-office traction, which we're not going to touch on today. But don't be scared to send those patients out, and it's not that, like, I have tons of chiropractors who refer scoliosis patients to me because we do bracing in our office. So we build a custom brace for the patient. I teach them their exercises and send them right back to their chiropractor for care. And you have great chiropractors in Ottawa who will do scoliosis braces for some of those complex cases that you need to do some sort of, walking traction, because a scoliosis brace is like a form of walking Dena roll. It's a walking Scoli roll. It's a walking traction that this patient can wear for hours a day while doing exercises to help improve their spine. So I'll show you guys who to refer to or what website to use if you want to use the docs who are in Ottawa who can help your scoliosis patients, and then they send them back to you for corrective care. Those are those complex cases with double and triple curves, especially when they're young and growing. Like, Dr. Ed talked about this. Here's a perfect example, right? Here's an 11-year-old, or she was 10 years old, right? And we just started this case recently. She's got, go figure. What did the spine surgeon told them? No big deal. She's probably going to grow out of it, right? Big psh to them. So this is a young girl with a 20-degree curve whose wrists are 0. This patient is like 100% going to get worse if we don't do something. It's wrist 0 because her triradiate cartilage is open here. And this is one of those cases where if we just leave her like that, that 20-degree curve is probably going to become a 30 or 40-degree curve in a matter of 2 years. And she has all of her growth left. So those cases where you see big curves and the patient is growing like crazy, those are those key ones that if it was in my office, I would be using other chiros in the area, get them a brace, and then keep doing your corrective care with them. Because the results that we can get in brace when they are going through those growth spurts, so between, like, we'll say 10 and 16 years old, or what we call risser 0 to risser 3, that is when we can have the biggest impact to take those bending moments, take that pressure off the spine. Because a 20-degree curve like that, this is actually going to change how those growth plates grow. So for instance, here we're starting to see some pressure on this growth plate. This side is going to have accelerated growth, and this side is going to have compressed growth, right? That's the Hütter-Volkmann principle. So as soon as you're above a 20-degree curve in a growing spine, those bones are starting to grow asymmetrically based on compressive and decompressive forces. And so the best way to get those forces off, get them adjusted, get them exercising, get them in a brace, okay? Those patients who aren't the high risk of getting worse, so those young patients with the big curves, well, what do we do with them? Corrective chiropractic care. It's a patient with a spine, the same as any other patient. Adjust them, get them going in your office. You're doing the same things with them. I will show you how I do my scoliosis specific adjustments. It's very, very, very simple. Okay. So basically, we're not treating them any other different than any other patient. What's different is what are they doing at home? So number one, instead of getting a dental roll, we're going to send them home on a Scoli roll. 20 minutes of Scoli roll use daily, again, for those single curve cases. And I put here with possible exercises, because for those of you who don't want to teach patients these different postural shifts while they're seated, we can have a patient lay on a Scoli roll and use their leg to do some different resistance exercises to get a better result by simply engaging the muscles of the spine while they lay on a Scoli roll. So I recorded a whole bunch of videos, and we're going to show you guys all of those videos today. Alternately, we can do Scoli roll, and we can also do these seated elongation exercises, which work amazing. Numerous times, Dr. Ed talked about the pressure, the compression, the bending moments, right? Well, the best way to take that off is to have them sit and elongate, take gravity off the spine. So we teach our patients how to sit in front of a mirror, and we have them elongate like crazy. And then we teach them these patterns of how to shift and take pressure off of those compressed disc areas and then try to hold it there. Once they become really good at that, then we give them resistance bands or little dumbbells, and we teach them how to do exercises while they're in this new corrected posture. And you send them home with that and let them work on these exercises with challenges, while they're in correction, to help get a better overall result for these scoliosis patients. And I'm telling you, the ones who do it consistently, the results are magic. And we just talked about this too. If you see those cases where they're growing, they've got a really big curve, especially if they're not going to be compliant with their home care stuff, there's a great chance that that baby's going to just keep going. Refer them out for a brace, and that chiropractor will send them back to your office to continue to do corrective care. Okay. So this is the company. You can use this website here. You can look, you could just type in, you could go to their doctor's directory, and basically you could put in Ottawa, and there are a few docs in Ottawa who are certified in these braces. They're all chiropractors, right? So they're not trying to take patients off of you. They're all like-minded chiropractors who want to help patients get better. And if you're interested in doing this yourself, get certified with them. I mean, 90% of what I know in scoliosis has all been learned by this gentleman and his team, Dr. Jeb McAvaney in Scoli Care. They offer courses in Scoli Balance. So like the exercises I'm teaching you today is like a watered down version of their in-depth hands-on seminars that they teach on how to do these exercises with patients, how to do bracing for patients. They do a phenomenal job at scoliosis care, and it's all chiropractor driven. All right, so here's those cases again. Now I'm just going to show you guys a couple of brace cases because I also have patients who come out of town. And I want you to understand the power of referring a patient for a brace. Here's this young gentleman. He's 10 years old, or he was 11 years old when he came in. His cartilage here just fused, so he's 0+. He's still got tons of growth left. He's got a 30-degree curve in his thoracic spine. Nobody knows what to do with him in Regina. So he's living about 5 hours away. Mom found us on the internet, comes in and says, what can we do with this kid? So we put him in a brace. We teach him exercises, right? A 30-degree curve in an 11-year-old who's growing, the risk of it getting worse is 90+%. So there's a 90+% chance that if we don't do something for this kid, he is going to get worse. So we put him in a brace. We teach him exercises. He's in Regina, so I only see him like once every couple months. But by just doing his exercises and wearing a brace, and look at him, this is him inside his brace. This is how powerful those braces can be. He's got a 30-degree curve. In brace, his curve goes down to 4.2 degrees, right? So I teach him his exercises. I give him a brace. He comes back 3 months later. We take an x-ray of him out of a brace, and already he's down to 19.8 degrees with wearing a brace 20 hours a day and doing these exercises consistently. These braces work awesome for kids who are growing. They are a great addition to your corrective chiropractic care. I will emphasize that over and over. Here's another one, a young patient. She lives far away, so I only see her every once in a while, but she's doing a brace and doing her exercises as well. She got a 30-degree lumbar curve. Guess what? The spine surgeon said, no big deal. We'll watch and wait. We'll wait for you to come back. And the spine surgeon told them that if they worked with a chiropractor, the spine surgeon would stop seeing them, right? Same thing. I would love to just, yeah, we'll leave that for another discussion. Anyways, she got a 31-degree lumbar curve. The curves that are most likely to get worse, even in adulthood, later on in life, are single curves that are unbalanced. In other words, there's a curve and the spine is shifted to the side because now you have gravity, you have these bending moments. These spines with time, with gravity, are simply going to break down through life. And once they're above 30 degrees, the chance of getting worse is almost 100%. So you've got a 31-degree lumbar curve in a growing teenager with an extremely sloped pelvis. Like you can see how oblique her pelvis is. This curve's only going to get worse with time, if not now, later through her life. So we put her in a brace. She's doing exercises. Within 3 months out of brace, 13-degree curve in her low back. The other thing I was telling you about, that Hütter-Volkmann principle. Check this out. So look at how this is being compressed because of all that gravity, because of that bending moment, that pressure. She's getting compression on these growth plates. By wearing a brace, by doing her exercises and taking that pressure off, look at how much her sacrum has been able to regain its normal shape and probably catch up in growth by 3 months of taking pressure off of that side. It's almost unbelievable how fast the spine can change in those growing teens. It's always serious. Any shifting, any problems you see, especially in those young spines, need to be addressed ASAP. Okay, so our 3 patterns of curve. Number 1, we're going to talk about our right primary thoracic curves. I mentioned single curves, but I want you guys to understand what I mean by a single curve is a primary curve. It's okay if you see a secondary curve or a compensation curve in the spine. It is extremely common to see that. Now, how do I know if it's compensatory or a secondary curve? Your primary curve is always going to be 30% bigger. So here's a 32-degree curve. Here's a 20-degree lumbar curve. This is simply a compensation. It's not a true curve. Okay. And so I can treat this like a primary thoracic curve because the 32 degrees is like, I can't remember what it is, 62%. This is 37%. The difference between the two, 12 degrees is about 37%. So as long as I am over the 30% difference between my two curves, my larger curve is my primary curve. I can use a Scoli roll. I can do the exercise patterns that I'm going to show you. Okay. So primary curves are 30% larger or more than their counterpart curves. The other way you know when they're typically compensatory, a lot of times like the bottom curves, those bottom end plates are going to be pretty flat. So like her bottom end plate here is not tilted. This is all compensation because of this right thoracic curve. All right. So what do we typically see in the posture or in the spine? We'll use this one as the example. So I just wanted to show you this case. So when we're talking about primary curves, you know that it's 30% larger or more. So this x-ray right here, we're looking at it A to P. So you see my L for left, but we're looking at her P to A. This x-ray is this young lady right here. She's a classic single thoracic curve, and obviously it's a huge curve, 65 degrees. So I chose this one because of the postural indicators are very evident. So number 1, you see the curvature, the red line follows her curve. You see right thoracic translation, which you almost always see on single thoracic curves. You see rib humping down here. So that means that those ribs have gone posterior in the lower thoracic spine, and the ribs actually, their shoulder comes posterior. So it's like a corkscrew effect. So she's translated to the right, the ribs are posterior here, and then she has the left shoulder that's posterior. All right, so let's show you this pattern here. So this is obviously not someone who has scoliosis. This is Julia, who works in our office. So she volunteered to do all these exercises so we could record all these videos. So I'm gonna let the video go through once, and then I'll explain the pattern again. Good. So you have someone sitting in front of a mirror on a stool so they can see themselves. It's very important that they can see themselves so they can understand how they're controlling their spine. Number 1, I went through this a minute ago. The number 1 thing we can always do with all of those patients is elongation. So the very first thing I have all my patients do, and that's why I have my hand behind her, I'm raising my hand. I cue them to is sit up nice and tall, right? So number one is have them get tall. I've taken x-rays on patients with scoliosis and I've made them just stand as tall as they possibly can. And you get correction in the curves just by simply having them fight gravity and improve their posture. Better posture, better spine. Shitty spine, shitty posture, just like Dr. Ed said. So get them tall. Number one thing is get them tall. Then what we want to focus on is right where my fingers are. It's pushing that forward, derotating that area. Okay. So you're going to see I help them push. I push, we derotate. Pause. I have them contract their abs as hard as they can. Contract your core muscles to try and stabilize that spine. And by doing that, we've brought this shoulder even further posterior, which we don't want because to start out with, it's already behind. So once they contract, I kind of keep my hand there to show them at first. And then what we have them do is bring that right shoulder blade back and try to let that front shoulder go forward. And then we have them translate left. And if I pause here, you can sort of visually see it. This patient now has a left thoracic curve, right? You're trying to do the absolute mirror image. Now, in a very stiff, rigid patient, it's not going to be that easy and it's not going to look this good. But in a more younger, flexible patient, you should be almost able to see the opposite curve pattern in them when they're done their active self-correction. So this is the active self-correction. You teach them this, send them home with it. I have them practice this over and over. I make them practice this for 15 to 20 minutes a day for a couple of weeks. And then when they come back and see us, we start adding exercises to this correction, which I will show you later on. So this is the simple pattern for a right thoracic curve. So let's go through it one more time. Okay. So if you're writing things down, you're taking notes, I know you get to watch it again, but it's simple. It's number one is elongation. Number two is that rib hump, push it forward. So derotate it. Contract the abs. Number three is bring that right shoulder down and back and let that left shoulder come forward. And then our last component is to translate over to the left. Get them to hold that. And then through their 15 to 20-minute exercise sessions, usually I have them hold it for 10 to 15 seconds at a time, relax, and repeat it over and over again. As they get better, they can hold these contractions for a minute, 2 minutes, 3 minutes. The longer they hold it, the better. Okay? So they practice this for 15 to 20 minutes a day. Then the Scoliosis rule. Whoops, let's go back to the Scoliosis rule. The Scoliosis rule, super simple. Find the peak of the curve, or where you think the peak of the curve is. And with right thoracic scoliosis, it's quite easy because you'll see a prominent rib hump. So you lay the peak of the Scoliosis rule at the peak of the curve. But what's important is to roll them backwards at an oblique angle. Because there's already a lot of rib deformity, you don't want to actually push laterally on the ribs. And I should have rotated her back more to make it more obvious, but let's go through that again. So if they're laying directly sideways, when I teach them this in the office, once they're laying on it, I roll them backwards to try and have that peak of the Scoliosis roll pushing at an oblique angle at the rib hump. You want to try and push at a bit of an angle. So I'm rotating her back, and it doesn't show it very obvious. We should have put the camera from above, but you want to roll them back probably about 30 degrees to have that Scoliosis roll peak pushing at the peak of the curve. Now, if you're using a Scoliosis roll with patients at home, if they have a single curve without any compensation, you could leave the head sort of sag down a little bit or have it in a neutral position. I want to go back to this slide though. Let's say you have a young gentleman like this young guy who has this kink up top. So he's got a right thoracic curve, then he's got a left kink. So his head already tends to then shift over to his left side, kinks over to the left like that. So when I lay him on the Scoliosis roll, I don't want his head, whoops, too far. I don't want the head to kink down like this. Remember, he would have had a right thoracic curve and then he had a left kink. So if I lay them on the Scoliosis roll like this and I let the head sag, you're actually making that kink worse. So if you see a compensatory kink up top going the other way in those right thoracic curves, what you do is you stack a whole bunch of pillows under their neck to try and crank their neck up the other way. Right? So you'll see I added a whole bunch of pillows under her neck here in a second. And as we lift the neck, pause. There we go. So now you'd have a much more neutral, and if anything, you're almost trying to curve that top kink or that compensatory curve the opposite way. Okay, so if you see a compensatory high thoracic curve, when you lay them on the Scoliosis roll, you want to see their head shift back to the opposite direction. That mirror image exercise I showed you. So elongation, derotation of the ribs, right shoulder back, left shoulder forward, and then translate over to the left. Here is an x-ray of a young patient with a right thoracic curve. She's 35 degrees. Okay. And then here is her doing her mirror image exercise. It goes down to 15 degrees. So amazing control, amazing correction. And, the more they do this, the stronger the muscles become. And throughout their corrective care, you keep doing this over and over and over again. And these little exercises will make a huge difference for maintaining those corrections in the end. So I want to show you this. It doesn't mean that you have to do this with every single patient, but sometimes doing these corrective exercises and taking an x-ray will just build your confidence, right? You start to own it and go, yeah, I know this is working and I know I'm doing the right thing. So I took an x-ray on her. I wanted to share it with you because it's a phenomenal result. Just by her doing that exercise that I showed you, she's reducing her thoracic curve by 20 degrees. And the other thing is to manage patient expectations. Dr. Ed also alluded to this. I can't remember who it was, one of the older scoliosis patients that he had shown, but it's better. Is it perfect? No. In a lot of these scoliosis cases, are they going to be perfect? Absolutely not. But that doesn't mean that we shouldn't be constantly working and reducing that chaos in the spine. That's like the best word possible, is reduce that chaos in the spine. And that chaos can be the curve magnitude. It can be amount of compression that you see on those discs. It can be the shifting, right? Anywhere that you can remove stress or chaos and pressure, you're helping that patient get well. And you have to understand that the longer that scoliosis has been there, the more degeneration, breakdown, the stiffer they are, the harder it is to see correction. So little changes, celebrate them, right? And set expectations like this young lady, I didn't even know if we could change this curve. It's 65 degrees, right? And now it's down to 56. So about a 9-degree change, right? That's huge. I was ecstatic. High fives in the office, because that is substantially worse than this spine, especially for, a 21 or 22-year-old female. The other thing is, she was shifted 8 millimeters to the right, and now she's 0.8, so she's better balanced. Curves get worse when they are off center. So even things like, even if that curve hadn't changed, but she had decreased her shift by 8 millimeters and she now had a better spinal position, better posture, better alignment, high five. Anything that you can do to improve these spines, you're helping them get well. Okay. But just understand, set expectations. The bigger the curve, the different it is, the less you're going to change it, plain and simple. Okay. If you see a curve like this, for instance, these are the curves we love. 10, 15-degree small curves. These are way more likely to change than a big 60-degree curve, a 50-degree curve. These are way easier to get corrective results on. And again, just like doing the stress x-ray of the exercise, if ever you're unsure if the patient is doing it right, have them do the exercise, take an x-ray. If ever you're unsure about where to place the scoliosis roll to make sure you're getting the peak right, have them lay on it. Here's a perfect example. Here we want to make sure we had the peak right. We had her lay on it, and boom, perfect. You take the x-ray, you can see it's doing exactly what I want it to. It's straightening out that spine perfectly. So if ever you're in doubt, bring a small adjusting table or a portable adjusting table into your x-ray room. Take the scoliosis roll, put it at the peak of the curve, have the patient lay on it, snap an x-ray, you can measure it, and then you can show them too. Hey, this is part of your home care. Do this every day. Here's the proof. This is going to work beautifully. Okay. A left thoracolumbar curve. Obviously, I'm showing you left because it's the most common that we see. For the exercise patterns, this would all apply for a right thoracolumbar curve as well. It would just be the mirror image of what I'm showing you. I'm showing you left because this is by far and away the most common one that we see. Okay, so you can see her curve here, big swooping curve, a lot of translation, and they're very evident in their posture. Like you can see the indentation here, and you can actually see that curvature right through here. Okay, so I put her picture A to P so we can kind of look at it from the front as well, but it's not nearly as evident as if we look at her from the back. You can see that swooping left thoracolumbar curvature right here. Now, the primary movement in the thoracolumbar spine is bending, right? That's what the thoracolumbar spine is meant to do, is bend. So the very first thing that we do, obviously, again, is elongation, but the second move is bending. So I'm going to put my hand right here. We're going to have them bend over the peak of the curve, right? So it's like you're trying to de-bend the peak of the curve. So they bend over the peak of the curve, pause. I have them contract their abs, track that correction. So now we've opened up that curve, and now we have them shift in a right oblique direction. So now they're going to shift up and over to the right, trying to elongate and open up that spine as much as possible, neutralize the shoulders, right? And then same thing, if I was to re-x-ray in this position, you'd probably see an opposite. You'd probably see a right thoracolumbar curve. They hold that, right? 10, 15 seconds at first, just trying to get them used to it. And then when they let go, you should see the spine collapse down and back. Beautiful. Okay. So again, for the thoracolumbar, always elongation first, have them bend over the peak of the curve, contract, hold that, and they shift. So they translate over to the right, trying to stay as tall as they can. And then I always have them try to neutralize those shoulders, straighten the head, hold, and relax. That simple. Now, my adjustments, scoliosis adjustments. You want to know how easy it is? I don't do anything different with them other than once I'm done, and obviously I'm doing this on the stool, but I would do this on my chiropractic table. I have them do the exercise that I taught them, mirror image exercise, and we blast them, flood them with proprioception from the arthrostim. That is the only thing I do different with adjusting scoliosis patients compared to any other patient. Make them do their corrective exercise, hold it, and then blast their spine up and down with the arthrostim. Takes 20 seconds. Okay. The thoracolumbar scoli roll. Now on this one, you don't have to rotate the patient at an oblique angle because there's going to be maybe a little bit of rib deformity, but it's very mild. And usually it's only going to hit the 12th rib. So they can lay perpendicular to the scoli roll. But if we look back with these thoracolumbar cases, they often need a lot of translation. Their whole spine, their whole body is kind of shifted over to that left side, kind of like, excuse me, you see right here. So sometimes the scoli roll itself is not even enough. We're going to use blocks, and at home I tell them to, go to the hardware store, go buy some insulation or some foam that they can build up, or they can use textbooks, whatever they have to try and build it up. So here I wanted to build more translation in the posture, so I did this in my office. So I used a Denerol block, but we added 20 millimeters under the block to help drive the posture over further. And you can see it, from the center of her tailbone here, there's quite a bit of translation in the posture over to the right side. But just like in that thoracic curve, when we're addressing the rest of the spine, we have to make sure if I'm going to increase the translation, or if I'm translating the spine over, I have to bring the shoulders and the head with it. I can't just put a thoracic scoli roll on a block and push in here and then let the head and shoulders sag down, because then I'm creating what? A right thoracic curve. So if you're going to translate, you're going to put more support under a block, you also have to put more support under the head and shoulders. So if I'm looking at this setup, it's an ideal setup. Sorry, let's do this. Because if I look at the top part of her spine, it's almost perfectly neutral. Excellent, right? I'm not letting any increased thoracic curve come into play. And this is my primary curve, so I'm just worried about putting pressure here. And as long as this looks pretty straight and neutral, I'm happy. And I just want to show you again how effective the scoli roll. So this patient right here, okay, this is her literally wheeled into the x-ray room. So there's her thoracolumbar curve, and then there's the peak of the scoli roll hitting it right there. Beautiful. Almost perfect correction. Back to managing expectations and little wins. And I show you these guys because these are not wow cases. This is this young lady here. This is her right here. I've been seeing her for about 2.5 years now. And typical, she started when she was 17. Now she's 19. She was motivated at first. We got great results. And like anything else, she stopped doing all the stuff at home. So at first, she started with a 40.9, so call it 41-degree curve. And for a while, we had her down to a 28-degree low back curve. She stopped doing her stuff. She stopped doing her scoli roll. She didn't come in as frequently. She wasn't doing her home exercises, and it went back up to 38 degrees. So this is not like something that you can just take your foot off the gas. These patients are going to have to do this scoliosis rehab for the rest of their lives in addition to their adjustments. But same thing, if we look over 2.5 years, is she still in a significantly better position here than she was here? Absolutely. Her curve is down by 2 degrees, but the biggest thing, again, what makes scoliosis worse is imbalance. So here she was shifted 14.5 millimeters to the left, and now the top part of her spine is actually measuring 3.3 millimeters to the right. So she's way better balanced. Overall, significant improvement in her spine, even though she can still afford to get that curve down even more. Lumbar curves. So the lumbar curves, when they're single lumbar curves, they will almost always come with some sort of pelvic obliquity. In other words, if it's a left lumbar curve, which is the most common, so if it's a right lumbar curve, just flip the exercise in the mirror image. So it's the same thing. You could do everything I'm showing you for a right lumbar curve. I'm showing you left because they are by far and away probably 80% of the curves you're going to see in the lumbar spine. They almost always come with some sacral obliquity. In other words, you're going to have a low pelvis on that side or a short leg. The slope of the pelvis tends to slope that way, which leads us to believe is why the scoliosis starts in the first place, because it is kind of compensating in a swooping pattern to try and bring the head back over top of the pelvis. So in these cases, number one, if they have a short leg, don't be shy to give them a heel lift to try and help to balance the pelvis out. But the biggest thing we see here, again, oftentimes is translation, because with that pelvic slope, the pelvis tends to shift, the pelvic slope allows the posture to shift over to that left side. Okay, so we can see it here. Green is obviously midline, and you see her whole body weight being over to that left side. That pressure, that compression, that's what starts to break down the spine. Okay, so in the lumbar curves, the very first thing that we want to try and do is translate them. So we have them seated, they elongate, they shift over. Okay, that's the very first thing that we do. They shift as far as they can. Then we have them not bend the same as we did in the thoracolumbar spine. It's more of like an isometric contraction in these muscles here. So basically, let me take that again. So they get tall, tall, tall. The lumbar spine pattern is identical to the thoracolumbar. It's just the opposite pattern. So instead of bending and then shifting, we shift and then we bend. Okay, so the thoracolumbar was bend, shift. This one is shift, bend, but the bend is very minor compared to the thoracolumbar spine, because we're not interested in bending over as much as we are trying to engage and strengthen those low back muscles. So it's elongation. They shift over to that right side and they contract the lumbar muscles. And always, if I see any tilt in the shoulders, I tell them neutralize your shoulders, straighten the head, don't add any pressure to the spine that you don't need, hold it, and relax. The lumbar scoliosis roll is probably the easiest one to use, right? You just find the iliac crest, and the iliac crest sits right into this cutout for the lumbar scoliosis roll. So it's super easy. You get the tip of the crest right there, and then automatically, boom, it's going to hit the lumbar spine, and you can see it almost creating this opposite curvature in the low back. All right, so I told you guys we have the corrections, and then we challenge them with exercises. So once my patients are good at doing their self-corrections, we give them an exercise band, right? Send them home with one, and I'll talk about it later. We started we bought a whole bunch of different Stroops exercise bands, so docs who do this stuff can buy some and then send their patients home with exercise bands. So we have them try to do an exercise while they're doing their correction. So you can see here she's holding her correction, and she's pulling her arms apart on a resistance band and trying to press up to the ceiling. And that's an awesome exercise for anybody with scoliosis, especially if there's any curve up top, because you see a lot of weak scapular winging. And so this exercise is awesome to strengthen the scapula. So they get into correction, and you teach them a super basic exercise with some resistance, and I have them do 20 repetitions. And then I move them to the next exercise. So I'll give them 3, 4, 5 different exercises to do. And I usually only start with a couple, and then as they get better, you can add some. And when you're doing these sessions, like we do them one-on-one in an exam room, and we charge $100 for scoliosis exercise consults. If you have a CA that you can teach this stuff to, great. Have a CA teach it to the patients, make sure they know what they're doing, and then charge for your time. Always charge for your time to do these things, okay? So here's a different one, super easy exercise, banded pull-aparts. So they get into correction, they pull a band apart, you're engaging way more musculature, and you're making it way harder for their brain to try and hold the correction. Very simple, very effective. And then the last one, you could do bicep curls. Now, if the patient had little dumbbells at home, I probably would teach them with little dumbbells. You could teach them with the resistance band, but tell them to do dumbbells at home. The sky's the limit. You could really do any exercises you want. I'm a really big fan of resistance bands because they're simple. I can keep them in my office. It's very easy to show the patient how to do it. And if they don't have any equipment, $20, $30 bands, they can buy them, go home, and do the exercises at home. Okay, so once you've taught them their correction, they're good at their correction, you can start implementing different resistance exercises. I keep it simple. I always tell them to do 20 reps of one exercise, and then move to the next and move to the next, up until about 7 total exercises for them to do at home. Now, if you say like, doc, there's no way I want to do that, way too complicated, that's way more time than I want to spend with them, then have them lay on their Scoli roll and have them start challenging their spine and their core by moving while they're on the Scoli roll. So we call this exercises on the Scoli roll. So we do 3 or 4 different patterns. Number 1, it's lateral raises with the leg. Number 2 is going forward and backwards. And then 3 is to do circles in each direction. So I have them do 10 lateral raises, 10 forward and backwards, 10 circles in each direction. And generally, if they do that slow and controlled, it's about a minute. I tell them to rest as long as they need, and then just keep repeating that throughout the time they do their 20-minute Scully roll at home. So obviously the seated exercises are much preferable. They're significantly better, but in certain cases, if you don't have time and you want to keep it simple, lay them on the Scully roll, teach them how to move their legs. Okay. Now, Dr. Ed had showed some x-rays of some older patients with some pretty severe degeneration, those patients that have compression fractures, big curves, and so on and so forth. And if you have double curves, big curves, compression fracture, someone in their 80s that's hunched and bent forward, obviously all of this stuff is way too complicated for them. And as I mentioned before, the most important piece is take gravity off the spine. So this is what I do with my patients who are in their 60s and 70s with big curves and a lot of degeneration. We have them elongate, and then we teach them how to push down with a pole. Just push down that pole. That engages their muscles. It makes them taller and takes more gravity off their spine. So I keep a PVC in the office, but I tell them at home, just use a broomstick, flip it upside down. It works perfectly fine. Okay. So you can see she gets tall, tall, tall. And then once they're as tall as they can, we have them grab that PVC or broomstick and push down with all their might and hang on to that for 10, 15 seconds if they can. Relax and repeat. Anybody with degenerative scoliosis or any real big postural breakdown absolutely loves this exercise. It feels so good because 1, it's an isometric contraction. It engages core muscles. 2, it basically unloads the spine from gravity. Okay. So here are the exercise bands that we've implemented. So now on our site, we have all kinds of different exercise bands. We started carrying these specifically to be able to do these types of scoliosis exercises or any real postural exercises with our patients. So you can find those on that site from now on. As always, there's a code for you guys, WQ423. It's good for 2 weeks, 10% off anything that you guys want to buy from the site as always. And you know the drill. Here's all my contact information.